So I'm going to talk to you about hypothermia and drowning today. We're going to start off by looking at classifying the severity, and there's a few different ways that we can look at this. And the key take home here is to do with the fact that we often don't have core temperature measurement devices available in the early stages of these cases. So clinical assessment is the key, and it will guide your therapy. So actually understanding the physiology of hypothermia is really important here. There's a couple of things we need to be aware of, such as after drop and circumrescue collapse. Those might not be terms that everyone's familiar with, so we'll go through those individually. I'm going to look at different strategies to rewarm patients and what we should be focusing on and what we should be avoiding. The definition of what drowning actually is, and some of the decision-making tools we have pre-hospital about when to transition from rescue to body recovery. And then we're going to finish off looking at the cardiac arrest guidance, which will be revision for everybody, I'm sure. And then finally looking at how we should anaesthetize these patients and when we should be thinking about extracorporeal life support, because we're really limited for ECLS options where we are geographically located in the UK. So a lot of the guidance that I'm going to be talking about today is coming from the Wilderness Medical Society guideline, and that was updated recently in 2019. So I would advocate having a look at this if you are interested in this topic, and it's all evidence-based, internationally accepted guidelines. So it's as up to date as you're going to get. Okay, so in terms of assessing severity, there are a few different strategies to look at this. Now, the WMS has a flowchart, which is really wordy. Don't look at it in detail. I just want to draw your attention to these three areas here. The key clinical things to look out for really when assessing hypothermia is whether or not the patient is shivering, what's their functional status, so what's their fine motor control like, and what's their conscious level. And that's been distilled down into this chart here. So a cold patient who's not hypothermic, we've all been in this situation ourselves. You're alert, you've got normal movement, and you shiver. When you start to become mildly hypothermic, so that's 32 to 35 degrees, you start to lose that manual dexterity, but you can still shiver. And it's not until you become moderately hypothermic, so less than 32 degrees, that you start to drop off your GCS and your shivering function. And it's really when you get below 28 degrees, which is severe hypothermia, that it becomes really dangerous. And those are unconscious cold patients, and their myocardium is very arrhythmogenic. So these are the patients we have to handle very carefully. And even transferring the patient from a trolley to a bed too quickly can transition them from a PEA rhythm or a sinus rhythm into ventricular fibrillation. So we need to be very careful we handle severely hypothermic patients. Now, the Swiss classification is a bit more user-friendly. 1, 2, and 3 is kind of mild, moderate, and severe hypothermia. We do have survivors in the UK literature below 24 degrees. They appear dead, often with PEA rhythms. I'll talk a little bit later about what that actually means, because it's not really a true PEA, it's just a low output hypothermic state. And there's an important distinction there between differentiating between a patient who is truly in PEA and somebody who's actually in a hypothermic low output state, because the management of those patients is subtly different. But once you get below 13 degrees, you are usually irreversibly cold. And we would classify those patients as to class 5 or dead. So some of the recommendations from the classification systems are that we should be classifying patients in terms of their grade of hypothermia based on clinical observations, because we often don't have core temperature measurement devices in the patient at that time, particularly if they're not intubated or ventilated. And you also need to think about other reasons for why a patient might be unconscious or not shivering, because they might have concurrent pathologies as well. So in terms of measuring temperature, an esophageal temperature probe is the gold standard. If you don't have access to one, then rectal and bladder temperature probes can be used, but there is a big time lag. And infrared tympanic thermometers shouldn't be used. And they shouldn't be used because they're unreliable when you get very cold. You need very specific types of low reading tympanic thermometers, which we don't, the only people that have those normally are the heart team. And any water or ice in the external auditory meatus will also cause them to underread. And this is tricky because often our patients, particularly in the pre-hospital field, don't have a core temperature probe down, which is why we have to be reliant on our clinical assessment to classify their status of hypothermia. Okay, so I want to move on to talk about a concept called after drop. So this probably isn't a familiar term to everybody, but what it's referring to is when a patient's core temperature continues to fall even after removal from a cold environment. And it happens for two reasons, either because of conductive heat loss, which is the minority of them, where you lose core temperature to your peripheral cold tissues, or convective heat loss, where you get blood flow to your peripheral tissues back to your skin, and you are moving your core temperature blood out to the colder areas. And part of the reason that tends to happen is because we're encouraging patients to move or to exercise too early after they've been removed from a cold environment. So one of the first aid recommendations is when you've removed someone from a cold environment who's truly got moderate or severe hypothermia, is we keep them still and we passively warm them first to avoid this after drop phenomenon. And it's particularly important for patients who are on that threshold between moderate and severe hypothermia, because if we drop them down below 28 degrees, then the myocardium becomes very arrhythmogenic. Okay, so circumrescue collapse is when a patient becomes lightheaded, syncopal, or transitions into cardiac arrest at the point at which they're being rescued. Now, there's a few theories as to why this might happen. Part of it's to do with mental relaxation, so patients kind of fighting for their life and they see that they're about to be rescued and they relax. They're also being often removed from a body of water, so there's a reduction in that hydrostatic pressure column that's been provided by the water itself. And maybe also mechanical stimulation of the heart. Again, if we're getting them to exercise and push cold blood back to the heart, then that may also transition them into a cardiac arrest state. And we try and avoid this by rescuing them in a horizontal manner, limiting their exercise and encouraging their attention or focus on what we're doing. Now, this might also be something that's relevant to our in-hospital practice. Again, if someone's very hypothermic, 29 degrees, for example, and we're getting them to move about, or we're moving them from trolley to bed too forcefully, then we could in theory transition them into the circumrescue collapse phenomenon. Okay, so in terms of rewarming, shivering is the most effective way to rewarm a patient. So encouraging hot drinks with lots of carbohydrates, if they're able to drink, is the way forward. It's very energy dependent. It uses a lot of ATP, but it will warm your core quicker than any other strategy, other than ECMO, of course. We avoid exercising very cold patients because we want to avoid that after drop phenomenon. We'll apply external rewarming strategies such as bear huggers, but be very careful about applying hot packs to the patient themselves. Their skin will be very poorly perfused, and even moderately warm heat packs will burn the skin because there's no cutaneous perfusion to distribute that heat away from the point of contact. So be very careful about how you do that. In terms of more invasive strategies, so pleural and peritoneal or bladder lavage, yes, it does work. It's slower than you'd expect. There are complications with it. And using intravenous warmed fluids, just be very careful not to fluid overload these patients. In recent memory, we've had a few patients who we have put on bypass over at City who've been very cold, but before they went on to bypass, had several litres of warmed crystalloid, and the RV was very strained when we were trying to transition them off bypass afterwards. So be careful with your intravenous fluid loads. Okay, so what do we mean by drowning? Well, there's a few definitions that we need to think about first and foremost. So immersion is when your body is immersed in a liquid, where you compare that to submersion, which is where the airway is below the level or the surface of the liquid itself. So drowning is asphyxiation due to submersion of the airway. Now, when you drown, a few things will happen concurrently. Your breath holds instinctively, until you have the urge to breathe because of the hypercapnia becomes overwhelming, at which point you'll aspirate fluids. Cerebral anoxia will onset, which will stop your breathing, and ultimately cerebral injury and anoxia will become irreversible. Now, in terms of cold water immersion, there are a few reflexes to consider as well. If you get your face cold and wet, that's called the diving reflex or the diving response. Now, it's predominantly a parasympathetic reflex arc, whereas when the rest of your body gets cold and wet, it's called a cold shock response. You'll become tachypneic and have predominantly a sympathetic stimulation arc. Now, patients who are in cold bodies of water, after they finish breath holding under the water, they'll have an autonomic conflict between their parasympathetic and sympathetic nervous systems. And some of these patients will deteriorate into a dysrhythmia very quickly, particularly if they've got cardiovascular comorbidities. And we think it's part of the reason why the rescue services are educating the public about lying on your back and trying to control your breathing. It's about trying to control your autonomic nervous system and stay controlled within the water itself. Okay, so when does rescue become body recovery? So there's no actual national ambulance service guidance about when, in terms of time delay between a patient becoming submerged and how long we should work towards. The rescue wheel on the left that I've got here is actually a fire rescue service recommendation and guideline. We will always rescue someone up to 30 minutes as a minimum because we feel that they are salvageable up to that point. One thing to say, though, is that if there's any possibility of any air pockets after patients become submerged, such as they're in a vehicle that's gone underwater, or there's been any indication that there's been an intermittent submersion, then we'll always rescue them for an extended period of time. If the water is very cold, then we'll extend that rescue period to about 60 minutes. And if the patient is very young or small, then we'll extend it to 90 minutes. Now, the reason for this is that if you can convince yourself, or you think there's a possibility that the patient's core temperature has got low before they became anoxic, then their brain will be protected. And we have fairly recently had a 60+ minute survivor in a child over in Herefordshire who was submerged in cold water, who left hospital neurologically intact. So you can survive extended periods of anoxia if you can get your core temperature low enough, quick enough. And the water temperature, which is really cold enough, is less than 6 degrees. Now, the average UK water temperature is 10 degrees, and you tend to only get less than that in coastal waters or kind of mountain rivers, streams, or bodies of water. So it's pretty unusual in the UK to have an environment where that would be applicable. Okay, so just a few key practice considerations before we move on to the ALS and ECMO stuff. A hypothermic cardiac arrest with no preceding hypoxia has excellent outcomes, and hopefully I've explained why that is in the last slide. Cardiac irritability is a major problem. As healthcare providers, we can convert survivable patients into non-survivors by careless handling if they're 28 degrees or lower. Core clinical management needs to focus on preventing cardiac arrest, so careful handling the patient and thinking about the myocardium, rewarming the heart effectively as soon as possible, and considering ECMO early. Okay, so in terms of the cardiac arrest management stuff, what do we need to think about? Well, we need to recognise patients who are futile. I will say, though, that fixed pupils, livido reticularis, which is pooling of blood in dependent areas, and rigor mortis are unreliable if they're very cold, because often patients will have all of those features and still be salvageable. But the avalanche rescue services use the following as being resuscitation futility parameters. So a serum potassium of more than 12, an incompressible chest, or fatal injury. So if your patient has any of those features when they arrive, then it's not appropriate to continue resuscitation. We need to assess for a pulse for at least a minute, so it's longer than we would do normally. Start CPR if there's a non-perfusing rhythm, so asystole, VF or VT, but do not start CPR if they're in a narrow complex PEA with a detectable end tidal CO2, or a moving heart on echo, because often those patients are just in a low output hypothermic cardiac state. And if you start CPR with those patients, you risk converting them into VF or VT. And a mechanical chest compression device is a must, because your resuscitation is going to be protracted. And get them plugged in. If you're using them in resus, just connect them via the cable to the AC power supply. Okay, so what does RC UK recommend? Well, you'll shock patients who are less than 30 degrees no more than 3 times. The Wilderness Medical Society advocate only a single shock. Any patient is above 30 degrees, then we'll transition back to normal guidance. In terms of circulatory access, IO is fine. If you're going to put a central line in, please use a femoral vein, because you want to avoid a wire irritating the myocardium if you go internal jugular, for example. Resuscitate with normal saline, because the liver can't metabolize the lactate and the Hartmann's when it's cold. Go with boluses and be very careful about the total volume that you give, because you can fluid overload these patients very easily. Don't treat hyperglycemia, do treat hypoglycemia, so give glucose if it's low. In terms of drugs, this will just be revision for everybody, I'm sure. You don't need to administer any drugs if they're less than 30 degrees. The drugs won't work, and it doesn't circulate properly if they're very cold. And if they're between 30 and 35 degrees, we need to double our dosing timings. Pacing, you can pace if you think it's indicated, but sinus bradycardic rhythms are a normal physiological response to hypothermia. We don't need to treat those. It will speed up as the patient becomes warmer. Okay, so let's say we've got a patient who's not in cardiac arrest, but is profoundly cold. How are we going to anaesthetize them? Well, if they need an advanced airway, that's fine. Just be gentle with how you do that. A video laryngoscope and gentle laryngoscopy is probably the way forward. Decompress their stomach as soon as possible, because it will be full of cold water, which will again drive their core temperature down. Trismus is often a problem, and it won't resolve with neuromuscular blockade, because the muscle is stiff because it's cold, not because it's got neuromuscular junction stimulation. Think about your cuff pressures as the patient starts to warm up. The cold cuff will expand as it gets warmer. Your end tidal CO2 will be low because the basal metabolic rate is low. So just set normal minute ventilation parameters on your ventilator, and then reassess the end tidal CO2 or the PA CO2 as the patient starts to rewarm. And of course, you're going to reduce your drug doses based on the patient's presenting GCS. Okay, so what about ECMO? Well, the guidance is pretty clear that a patient who's moderately hypothermic should be transported to the nearest closest hospital. But patients who are in hypothermic cardiac arrest, are hemodynamically unstable because of the hypothermia, or are less than 28 degrees, needs to go to the nearest extracorporeal life support capable hospital. Now, we're limited with that in the Midlands. Options are Wythenshawe in Manchester, Alderhay in Liverpool, and RVI in Newcastle. Now, Glenfield has a VV ECMO referral pathway. They do have capability for VA ECMO for transitioning patients off pump. There is a hypothermia SAP at Glenfield. We haven't been able to successfully access that as of yet, so we are working on tightening up the governance around that. But I think pragmatically, if a patient arrived at QMC who needed extracorporeal warming, sending them to City for bypass is probably the quickest option that we have available to us. Now, we have tried to do that on a few times in the last 10 years that I can remember, but we've done it really late. So if you have a patient or pre-alert for a patient who's very cold and is cardiovascularly unstable, please think about this as an option early. Be on the phone to the cardiac surgeons and the cardiac anaesthetists early, because if we're going to make this work and salvage patients in this context, they need to be probably out the door at Queen's within 5 minutes of them arriving for it to be pragmatically possible. And of course, any patient with traumatic injuries just needs to go to a major trauma centre. Those are the priority over their hypothermia management. So, bit of a shorter talk today. That's all I have to say. Thinking over some questions.